Hi friends, welcome back. Once again, welcome back to the Nurse channel. So you all know that we have started our preparation for SCT, IMST and the upcoming JIPMER nursing examination. And we have already uploaded some series of questions. And I request everyone who didn't watch the videos yet, kindly go through those videos. And today also we have come up with another set of 15 questions which are very important questions which will definitely help you to prepare for the upcoming nursing officer examinations. Okay, so before starting our session, two things I want to tell you. The first thing is the questions what I am going to explain in the sessions may look very simple for you, so please don't skip the videos, because whatever I am giving you the explanation is very important. Okay, so each point I am explaining in this session is very important, so kindly watch the video without skipping till the end. And another thing, important thing is, whoever not yet subscribed our channel, kindly subscribe our channel and support us. So straight away we will move on to the next series of questions for the preparation of SCT, IMST and JIPMER examination. Okay, so straight away into the questions. So here comes the first question in our present series, that is a SCT JIPMER series. So the first question for you is in the screen right now. So this is a question to expand the abbreviation. So what does CEA stands for? Okay, so you have to expand CEA. Okay, so the options for you are: the first option A, carcinoembryonic antigen; the second option, chorioembryonic antigen; the third option, common embryonic antigen; and the final option, cancer embryonic antigen. So how you will expand CEA? So what is the answer? It's quite confusing. So we will see the answer. The answer is option number A, that is carcinoembryonic antigen. Okay, so what is carcinoembryonic antigen? We will have a look on that. So CEA measurement is mainly used as a tumor marker to monitor the colorectal carcinoma treatment. Okay, so the CEA means it is a measurement, is mainly it is used as a tumor marker. So regarding the tumor marker and the types of tumor marker, already we have discussed in our old series. So whoever didn't watch that videos yet now, will kindly go back and watch those videos also. Okay, so this is a tumor marker which is used to monitor the colorectal carcinoma treatment. Okay, and to identify the recurrence after the surgical resection, and for the staging or to localize the cancer spread. Okay, so the carcinoembryonic embryonic antigen, it is a tumor marker, and mainly it is focusing on the treatment of the colorectal carcinoma. Okay, for the diagnosis and for the treatment purpose. Okay, treatment purpose in the sense how the level of treatment also can be, level of achievement of the treatment goals can be monitored with the help of CEA. It is a tumor marker. Okay, and the CEA, it is normally produced in the gastrointestinal tissues during the fetal development. Okay, so during the fetal development the CEA is normal, but the production will decreases after birth. Decreases means it completely, it will stops after the birth. Okay, so that's all about the CEA. I think it is understood that CEA is the carcinoembryonic antigen test, mainly aimed at colorectal. Okay, aimed at the colorectal carcinomas, and it is normal during the fetal life, and the production will stop after birth. Okay, so the second question for you is from the obstetrics and gynecology, and the question is: calcium requirement during pregnancy and lactation is. So how much calcium is required during, extra calcium is required during pregnancy and lactation. Okay, so you know the importance of why calcium we have to take during, ladies have to take during their pregnancy and lactation period. Pregnancy period for the bone and the skeletal development of the fetus, and for the mother's well-being also, and during the lactation also the same thing. Okay, so the options for you are: option number A, 0.5 gram per day; option number B, 2 gram per day; option number 3, 1.3 gram per day; and the final option number 4, 1 gram per day. So what is the daily requirement of calcium during pregnancy and lactation? 0.5, 2, 1.3, 1. So what is the answer? So the answer is 1 gram per day. Okay, so we will have a small explanation about the calcium requirement during the pregnancy. So we know that the pregnant women need about 1 gram, that is 100 milligrams of calcium a day, and if the woman is in 18 and younger, then they need 1.3 milligrams per day. Okay, so normally you should think about a normal woman above 18 years of age. For them the requirement is 1 gram per day, but if the lady is 18, if the girl is 18, and younger then 1.3 milligram per day is the requirement. So oral swallowable calcium tablets to be administered, to be taken twice a day, that is total 1 gram calcium per day starting from the 14th week of pregnancy. Okay, so this is another point for you to remember. So when onwards that calcium tablet need to be started, that is from the 14th week of pregnancy, and it has to be continued up to 6 months and sometimes up to 1 year. Okay, till the breastfeeding continues, till that time ladies can continue taking calcium tablet. Okay, so from this question you are getting 3 information, that is the daily requirement for a normal pregnant lady is 1 gram. If the age of the lady is 18 years or younger, then it is 1.3 gram. Then when onwards this has to be started from the 14th week of pregnancy and up to 6 months or sometimes up to 1 year. Okay, so that's all about the second question. Now we will move on to the third question. So it is a picture based question. So the question is here, you have to identify the needle what you are seeing in the screen right now. Okay, so you have to identify this needle. What is this needle called? Okay, that is a question for you, and the options for you are, the first option is bone marrow aspiration needle, the second option is intravenous cannula, the third option is spinal needle, and the final option is intravenous catheter. Okay, so what is this? What is this needle? So you know that this is a needle. So identify which needle it is, whether it is a bone marrow aspiration needle or intravenous cannula or spinal needle or intravenous catheter. So what is the answer? So definitely the answer is, I think you all know, and this is the spinal needle. Okay, these are different sizes of spinal needle. Okay, so we will see, then we will see each one in brief. Okay, so the first one, the answer of our question was the spinal needle. So this is a picture of the spinal needle of several sizes, and you know that the spinal needles are used for the lumbar puncture or the spinal anesthesia or the diagnostic puncture of the spinal canal. Okay, so this is the purpose of the spinal needle. It is for the lumbar puncture or the spinal anesthesia or for the diagnostic puncture of the spinal canal. Okay, and we know that the sizes, the spinal needle generally used today are 22 to 27. Okay, 22 to 27 gauge, that means that is an adult size, but sizes ranging from 19 to 30 gauge are also available. Okay, so you are getting additional information here, that sizes, the spinal needle sizes range from 19 to 30 gauge. Okay, so that's all about the spinal needle. And the other option what I have given in the question was regarding the bone marrow aspiration needle. So this is the picture of the bone marrow aspiration needle, and you know that bone marrow aspiration is a procedure in which a small sample of the bone marrow is removed, usually from the hip, breastbone or the thigh bone. Okay, so this is an additional information for you. So from where the bone marrow aspiration is done, so it is usually from the hip bone, breastbone or from the thigh bone. Okay, and the bone marrow aspiration needles are available in sizes like 14 size it is available, 16 gauge it is available, 18 gauges it is available, and its length is 5 centimeters. Okay, so bone marrow aspiration needle available sizes are 14, 16 and 18, and its length is 5 centimeters. Okay, so that's all about the bone marrow aspiration. So what is bone marrow aspiration and what are the bone marrow aspiration needle sizes we have explained, and this is the picture of the bone marrow aspiration needle. Okay, and one more option what I have given in the question was the IV cannula or the IV catheter. So everyone knows what is a IV catheter and IV cannula. So the one additional information I can provide to you is the most common sizes ranges from the IV cannula or the IV catheter sizes ranges from 14 to 22 gauge. Okay, 14 gauge to 22 gauge, and higher the gauge number, you know that the smaller is the cannula size. Okay, higher the gauge number, smaller is the cannula, and the size ranges from 14 to 22 gauge. Okay, so that was a picture based question, and it is also very important, and from this question you are getting information regarding the other 3 items also. Okay, so I think it is useful to you now. Now we will move on to the next question in our series, that is the 4th question. So this is from the oncology again. So what is the most common site of spread of epithelial ovarian tumors? Okay, so this is a very important question, and it is little tough also, but try to understand that what is the most common site of spread of epithelial ovarian tumors. Okay, so the options for you are the option number A, bone, option number B, liver, option number C, lungs, and final option number D, peritoneum. So where epithelial ovarian tumors can spread. So what is the answer? So here the answer is option number D, that is peritoneum. Okay, so peritoneal spread will be more for the epithelial ovarian tumors. Why? Because the epithelial ovarian cancers tend to grow locally and spread within the pelvis and the abdomen rather than by the hematogenous or the lymphatic dissemination. So distant metastasis occur very late. Okay, so the question was, which is the commonest site of ovarian cancer metastasis? Epithelial ovarian cancer. So epithelial ovarian cancers, they will grow very locally and will spread to within the pelvis and the abdomen. So in the options we got peritoneum is there, that is in the abdominal cavity. So peritoneum is the most common site, and this epithelial ovarian cancers, they won't spread hematogenous spread, or the lymphatic dissemination is not more common. Okay, so the distant metastases also are very rare, or it occurs very late. Okay, so that's all about the fourth question. Now we will move on to the fifth question. It is from the embryology. So the question for you is, gonads develop from which embryonic layer? Okay, this question is very simple and direct, but you should learn so many things from this area. Okay, gonads develop from which embryonic layer? And the options for you are option number A, both mesoderm and endoderm. Option number B, mesoderm. Option number C, ectoderm. And option number D, endoderm. So from which embryonic layer you can expect the gonads develop? So what is the answer? So the answer is option number B, that is mesoderm. Okay, so we have to understand what is mesoderm, or ectoderm and endoderm, and what all are structures that are developing from these embryonic layers. So in a very briefly, I will explain to you in the explanation of this question. So we will first see what is a germinal layer or what is an embryonic layer. So these adult tissues are derived from three embryonic cell layers called the germinal layers. Okay, and the outer layer is the ectoderm, the middle layer is the mesoderm, and the innermost layer is the endoderm. I think you know this. Okay, so germinal layers means our tissues are derived from the embryonic cell layers. They are called as the germinal layers, and the outer one is the ectoderm, the middle one is the mesoderm, and the innermost one is the endoderm. Okay, so now we will see from endoderm what all things are developing. Okay, so it forms the epithelial lining of the whole of the digestive tract. Okay, the whole of the digestive tract except part of the mouth and the pharynx and terminal part of the rectum. Okay, so the whole digestive part except mouth and the pharynx and the terminal part of the rectum. So these things are lined by the ectoderm. Okay, so the first thing, digestive tract, then the linings of the glands which opens into the digestive tract, including those of the liver and pancreas. Then it is lining the epithelium of the auditory tube and tympanic cavity, the cochlea, bronchi, alveoli of the lungs, the bladder and part of the urethra, and the follicle lining of the thyroid gland and thymus. Okay, so these things are developed from the endoderm. Mainly it is focusing upon the epithelial lining of the digestive tract, then glands which are opening into the digestive tract, then the epithelium of the auditory tube, tympanic cavity, cochlea, bronchi, alveoli, then bladder and part of the urethra, then follicle lining the thyroid gland and thymus. Okay, so at least this much you should understand about the endoderm. So from any of these areas you can get questions like, the digestive tract is lined by, it is formed by digestive tract epithelium lining is formed by which embryonic layer? Like that questions also can come. Okay, so next we will explain about the mesoderm. So the what all things are developing from the mesodermal layer. So the notochord, that means the vertebrae development, then the kidney, gonads, cartilage, skeletal muscles and dermis, the circulatory system, that is including the heart and the spleen, the wall of the gut and wall of the human body. Okay, so these things are developed from the embryonic layer, mesoderm. Our question was regarding the gonads. So gonads and kidney, cartilage, skeletal muscles, dermis, circulatory system including heart and spleen, and the wall of the gut and the wall of the human body. These things are developing from the middle layer of the embryonic layer or the germinal layer, that is mesoderm. Now we will see what is ectoderm. Okay, what all things are developing from the ectoderm. From the ectoderm you will get epidermis, hair, nails, lens of the eyes, sebaceous glands, cornea, tooth enamel, the epithelium of the mouth and the nose, then peripheral nervous system, adrenal medulla, melanocytes, facial cartilage, brain, spinal cord, posterior pituitary, motor neurons, retina, etc. Okay, so the central nervous system like the brain, spinal cord, those things are developing from the ectoderm. Then hair, nail, lens of the eye, sebaceous glands, cornea, tooth enamel, then the peripheral nervous system, adrenal medulla, melanocytes, pituitary, posterior pituitary, motor neurons, retina. These most important things are developing from the ectoderm. Okay, so in short, I have explained about the 3 layers of germinal layers. I think this will be you should understand it very neatly. Okay, you can expect questions from these areas, and you should not miss any questions that is coming from these embryonic layers. Okay, so I think that is clear for you now. Now we will move on to the another question, the 6th question in our series. And the question is very simple, but it is little confusing. Hormone responsible for the development of corpus luteum is dash. So the question is, hormone responsible for development of corpus luteum is dash. So the options for you are option number A, FSH, option number B, LH, option number C, ICSH, and option number D, progesterone. So the hormone, which hormone is responsible for the development of corpus luteum? That is very, very important. Development of corpus luteum, that is a clue for you. Okay, so the options are, first one is FSH. What is FSH? That is follicle stimulating hormone. Then what is LH? That is luteinizing hormone. Then what is ICSH? That is interstitial cell stimulating hormone. And the final option is progesterone. So what is the answer? So the answer is definitely LH. LH is the answer for the question, development. Okay, so we will see what is LH. So LH is the luteinizing hormone, otherwise known as the luteinizing hormone or the luteinizing hormone, lutropin, and sometimes known as a lutrophin. Okay, so it is a hormone which is produced by the gonadotropic cells in the anterior pituitary. Okay, so this is produced by gonadotropic cells which is in the anterior pituitary gland. Okay, so you are getting a bunch of information from this question, and the production of LH is regulated by gonadotropin releasing hormone, that is GnRH. Okay, so its production is regulated by the GnRH and it is from the hypothalamus. Okay, so now we will see what is the action of LH in males and females. Okay, so in females, an acute surge of LH, that is LH surge, triggers the ovulation. So ovulation hormone is LH, and it helps in the development of corpus luteum. Okay, so here you should understand very careful that the development of the corpus luteum is done by the LH in females, but the corpus luteum later will produce a hormone called progesterone. So it helps LH helps in the development of corpus luteum, and from the corpus luteum, which hormone will be released? Progesterone will be released, and this progesterone will be supporting for the upcoming pregnancy. If the lady is getting pregnant, then the pregnancy will be protected by this progesterone which is released by the corpus luteum, and the corpus luteum development will be happening with the help of hormone called LH. So don't be confused between LH and progesterone. I think it is clear for you now. Whenever you are thinking about the LH, just think about ovulation and then the development of the corpus luteum. Okay, and in males, on the other hand, in males, what LH is doing is it is also known as the interstitial cell stimulating hormone. Okay, so LH is otherwise known as interstitial cell stimulating hormone in males, and it stimulates the Leydig cell production of testosterone. Okay, so it helps in the production of testosterone from the Leydig cells. So that's why they are known as the interstitial cell stimulating hormone. Okay, so I think that confusion is clear now. LH for the development of corpus luteum and for the testosterone production in the interstitial cells of testis or the Leydig cells of the testis, and it is known as the interstitial cell stimulating hormone. Okay, and from the corpus luteum, which hormone is producing? That is progesterone. Okay, so I think that question is clear for you now. That was the 6th question. Now we will move on to the 7th question, and it is a very common simple question. Waiter's tip position is seen in. So the question is very simple, and it has asked many times in many examinations. So waiter's tip position is seen in. Waiter's tip position is seen in. So the options for you are, the first option is A, Bell's palsy, the second B, facial palsy, so the third Erb's palsy, and the final option, congenital dislocation of hips. So what can result in waiter's tip position? So what is the answer? It's a simple question. So the answer is obviously option number C, that is Erb's palsy. Okay, so how this waiter's tip position? So Waiter's tip position, how it is coming, that we will have a small explanation about this question. So Erb's palsy, what is Erb's palsy? Erb's palsy is the paralysis of the arm caused by injury to the upper group of the arm's main nerves, specifically that serving the upper trunk C5 C6 nerves. Okay, so this is the injury of the upper group of the arms, nerves of the arms, and especially the C5 C6 nerves. Okay, so what will happen if Erb's palsy happens? What will happen? So the arm hangs by side. Okay, so arm will be there in the side and it is rotated medially. So towards medially it will be rotated, and the forearm is extended and pronated. Okay, so the forearm will be extended and it will be pronated, and the arm cannot be raised. This arm cannot be raised from the side, that all powers of flexion of the elbow is lost in this, and the supination of the forearm also lost. Okay, so the peculiarity of Erb's palsy is that the forearm will be extended and pronated, the arm cannot be raised from the side, and all powers of the flexion of the elbow will be lost, and supination of the forearm also will be compromised. So what happening is the resulting biceps damage is the main cause of this classic physical position commonly called as the Waiter's tip. Okay, so the another question what you can expect from this area is what is the main cause of the physical appearance of Waiter's tip in Erb's palsy? This is due to the damage to the biceps. Okay, so the biceps damage is resulting in the classical positioning called Waiter's tip. Okay, so that's all regarding the Erb's palsy. And actually one more option was there, that is the Bell's palsy. You know that Bell's palsy, otherwise known as a fascial palsy, and it is occurring because of the inflammation or any other trauma to the cranial nerve 7, that is a facial nerve, that is Bell's palsy. Okay, so just an additional information for you. Now we will move on to the 8th question in our series. The 8th question, it is from the pharmacology, and the question is pharmacodynamics involves the study of all the following except. So the question is pharmacodynamics involves the study of all of the following except. Okay, the options for you are: the first option is biological and therapeutic effects of the drug. The second option, absorption and distribution of the drugs. The third option, mechanisms of drug action. And the final option, drug interactions. Okay, so pharmacodynamics involves 3 out of these options except 1. Okay, so what is the answer? So the answer is option number B, that is absorption and distribution of the drugs. Okay, so pharmacodynamics includes the biological and therapeutic effects of the drug, its mechanism of action, and the drug interactions, whereas the pharmacokinetics. Okay, so we will see the explanation for this question. So 2 things you have to understand. The first one is the pharmacokinetics. So what is pharmacokinetics? It is currently defined as the study of the time course of drug absorption, distribution, metabolism, and excretion. Okay, so pharmacokinetics is defined as the study of time course of the drug absorption, drug distribution, metabolism, and excretion. And on the other hand, pharmacodynamics, it is a study of the biochemical and the physiological effects of the drug. Okay, so the question was regarding the pharmacodynamics. So pharmacodynamics, it is the study of the biochemical and physiological effects of the drug, whereas pharmacokinetics is the time course of drug absorption, distribution, metabolism, and excretion. Okay, so that also is very, very important. So now we will move on to the next question, that is the 9th question in our series. So this is also an important, very, very important question. Screening test for prostatic cancer or prostatic enlargement in old age is. So this is a diagnostic question from oncology. So the screening test for the prostatic cancer or the prostatic enlargement in old age is. So the options for you are: the option number 1, the first option is serum creatinine level. The second option, serum cholesterol level. The third option, blood sugar level. And the final option, PSA level. Okay, so what is the answer? Options are serum creatinine level, serum cholesterol level, blood sugar level, and PSA level. So what is the answer for the question? Screening test for prostatic cancer. Simple question, but it's very, very important. So the answer is PSA level. So what is PSA? What is PSA stands for, that we will see in the explanation. PSA, otherwise known as the prostate specific antigen, and it is secreted by the epithelial cells of the prostate gland. Or you know that the prostate gland is present only in the males. Okay, so the prostate specific antigen is secreted by the epithelial cells of the prostate gland. And what is this PSA meant for? So the PSA levels under 4 nanogram per ml are generally considered to be normal. So if the PSA level is less than 4 nanogram per ml, then it is considered as normal, and if the value is between 4 to 10, that indicate a risk of prostate cancer or prostate enlargement. Or when the PSA level is above 10, then there is a higher risk for the development of prostate cancer. Okay, so in the options, the other options what I have given in the question was serum creatinine level. That can also be confusing, because many of the patients will come to the clinical settings or to a medical practitioner telling that the frequency of urination has increased, and the other issues related to the urine, okay, urination. So definitely you will have a thought like whether serum creatinine also need to be tested, but the specific test for understanding the prostate enlargement is serum, that is a PSA level, that is prostate specific antigen. Okay, I think that is clear for you now. Now we will move on to the next question in our series, that is a 10th question. This is from anatomy. This is also very important. Deep fascia which covers the thigh is called as. Okay, so this is also a common question. Deep fascia which covers the thigh is known as. Deep fascia which covers the thigh. So the options for you are option number A, fascia lata, option number B, dartos fascia, option number C, scarpa's fascia, and option number D, camper's fascia. Okay, camper's fascia. So what is the answer? Deep fascia which covers the thigh. So the answer is option number A, fascia lata. Okay, so this is the deep fascia which covers the thigh. So then what is dartos fascia, what is carpus fascia, what is camper's fascia? So that we will see the explanation of this question. And the first thing was the fascia lata, otherwise known as the FL. It is a facial plane that surrounds the deep tissues of the thigh. That was a question I asked. Now we will see what is a dartos fascia. So the dartos fascia is a layer of connective tissue found in the labia, in the penile shaft, foreskin, and in the scrotum. Okay, so the dartos fascia is a layer of connective tissue which is found in the labia, in the penile shaft, foreskin, and scrotum. Okay, so I think dartos fascia is clear for you now. Then another option was regarding the fascia of Camper and the fascia of Camper, okay, and the scarpus fascia. These are the other two options. The fascia of Camper is a thick superficial layer of the anterior abdominal wall. So these two are the fascia of Camper and the scarpus fascia are the layers of anterior abdominal wall. The superficial fascia is composed of two layers. Okay, actually there is a fascia called the superficial fascia in the anterior abdominal wall, and it has two layers. The fatty outer layer is known as the Camper's fascia or fascia of Camper, and the more membranous inner layer is known as the scarpus fascia. Okay, so the superficial fascia has two layers. The first one is the Camper's fascia, that is the outer layer, and it is very fatty and it is very thick, and the inner layer is the more membranous layer, that is known as the scarpus fascia. Okay, so from this question you have learned about what is fascia lata, what is dartos fascia, then fascia of Camper, and fascia of and scarpus fascia. Okay, so bunch of information again from a single question. Okay, so now we will move on to the next question in our series, that is the 11th question. So the question is, a drain that is used for drainage of bile after an open cholecystectomy is. So the question is very clear. A drain that is used for drainage of bile after an open cholecystectomy. Okay, so the particular drain that is used for drainage of bile after cholecystectomy. Okay, so the options for you are, the first one is the Jackson-Pratt drain, then the second option is the Hemovac drain, the third option is the Penrose drain, and the final option is the T-tube. So what is the answer? So all the options I have given to you are different types of surgical drains. Okay, so in that, which one is particularly used for the cholecystectomy patients, for the removal of the drainage? So what is the answer? It's a little tough question. So the other options, the answer for this question is Option number D, that is T-tube. Okay, so now we have to understand what is a T-tube, what is a Penrose tube, what is Hemovac, and what is Jackson-Pratt. So we will see each one in brief. The first one is the T-tube. So this is a picture of the T-tube. You can see in the screen right now. So a T-tube is a T-shaped tube. As the name indicates, it is a T-shaped tube placed at the common bile duct. Okay, so it can be placed at the common bile duct, so that what will happen following the procedures involving the duct, such as after the cholecystectomy or the cholecystectomy, etc. Okay, so it can be placed in the common bile duct. For that placement only we have the T-shaped tube, and this is particularly used for the patients after the cholecystectomy or the cholecystectomy, like surgical procedures of the bile. Okay, gallbladder, of the gallbladder. So now the other option was the Jackson-Pratt drain, or otherwise known as the JP drain. So this is a JP drain picture, and the Jackson-Pratt drain, also called as the JP drain, it is a closed suction medical device that is commonly used as a postoperative drain for collecting bodily fluids from the surgical site. Okay, so don't be confused, because our question was particularly related to the gallbladder surgeries. Okay, so this is also can be used for other surgeries to drain out the secretions. Okay, this is also a closed suction medical device, that is Jackson-Pratt. Then another was the Hemovac, that is otherwise known as a Hemovac drain and all, which can be used for the cranial surgeries or the abdominal surgeries also. This is also a portable wound suction device that is compressed to provide the gentle suction, and an internal spring slowly expands to create a negative suction pressure of approximately 45 millimeters of mercury. Okay, so this is also a suction wound suction device, and it is a drain, and it will provide a suction pressure of approximately 45 millimeter of mercury. This can be also used for the after the surgeries, abdominal surgeries, cranial surgeries, etc. So the another option was the Penrose. What is Penrose drain? So this is a picture of the Penrose drain, and it removes the fluid from the wound area. And this Penrose drain is usually used for podiatries, like the nail surgeries, the leg surgeries and all. So a Penrose drain is often used as a tourniquet during a nail avulsion procedure or ingrown toenail extraction, and it can also be used to drain the CSF to treat the hydrocephalus patients. Okay, but it is not used much in clinical settings, but you should understand about this Penrose drain also. Okay, so mainly for the nail avulsion procedures and the toenail extraction, and for the draining the cerebrospinal fluid in the hydrocephalus patients. Okay, so that is a Penrose drain. So once again, a bunch of information from a single question. Okay, so now we will move on to our next question in the series, that is the 12th question, and the question is, which of the following is the drug of choice in drug-induced anaphylactic shock? Okay, so this is another very important question. So which of the following is the drug of choice in drug-induced anaphylactic shock? Drug-induced anaphylactic shock. So the options for you are, the first option is A, noradrenaline, option number B, adrenaline, option number C, dopamine, and the final option number D, heparin. So which is the drug of choice for drug-induced anaphylactic shock? So what is the answer? So the answer is adrenaline or epinephrine. Okay, adrenaline or epinephrine. So you know that the normal response of the body to an anaphylaxis is the release of the adrenaline. Okay, so you know that the body's natural response to anaphylaxis is to release adrenaline or epinephrine, a natural antidote to some of the chemicals released as part of the severe allergic reactions. So this means whenever there is a severe allergic reaction or anaphylaxis happens, then some harmful chemicals will be released into the body, and these chemicals, the antidote for this chemical is the adrenaline. Okay, so that is the body's normal response. So when there is a severe anaphylactic reaction, then externally we can give adrenaline to combat with these chemicals. So therefore injected adrenaline assists in the body's natural response. Then definitely I am asking you a question, why noradrenaline is used for this purpose, this anaphylactic shocks? Why? So can you answer that question? Why noradrenaline is not used in the anaphylactic shock? So we know that the epinephrine or the adrenaline, it has a greater effect on the beta receptors compared with the norepinephrine. Okay, so alpha receptors are only found in the arteries, but beta receptors, they are found in the heart, lungs, arteries of the skeletal muscles, etc. Okay, so because of that reason, noradrenaline is widely used as a drug of choice in anaphylactic reactions. Okay, so noradrenaline is not used. So adrenaline has a greater effect on the beta receptors compared with the norepinephrine. Okay, so alpha receptors are only found in the arteries, but beta receptors are found in heart, lungs, and arteries of the skeletal muscles. Okay, that is the reason why adrenaline is a drug of choice for anaphylactic reactions. Okay, I think that is clear for you now. Now we will move on to the 13th question in our series. It is a simple question. What carries the greatest risk for breast cancer? Okay, so what carries the greatest risk for breast cancer among the options? Okay, so I'll give you the options. So from these options you find out which is the greatest risk for the breast cancer. The first option is family history of breast cancer. Then the second option is nulliparity. The third option is oral contraceptive usage. And the final option is previous contralateral breast cancer. So this is a very simple question. Family history, nulliparity, OCP, contralateral breast cancer, previous. That means previous history. So definitely the answer is option number D, that is previous contralateral breast cancer. Okay, so other options what I have given are also the risk factors for some more the other risk factors for the development of breast cancer. But if the patient is already had a history of breast cancer in the other breast, then the chances of getting breast cancer to the other non-affected breast also is very high. Okay, so that is the answer for the question. So straight away we'll move on to the second last question in our series, that is the 14th question for you. Which of the following type of grafting technique is used for burn patients? Okay, so burn patients, which grafting technique is used? Okay, so that is a question for you, and the options for you are option number A, exografting, option number B, xenografting, option number C, autografting, and option number D, heterografting. So what is the answer? Exografting, xenografting, autografting, heterografting. So just think about these options and think about the advantages of some of these options, and you can answer this question very easily. So what is the answer? So the answer is option number C, that is autografting. Why autografting? So what is autografting? That we will see in the explanation for this question. So first of all, what is autograft or the autologous graft? So from the name itself, it is clear that auto. So the skin will be obtained from the patient's own donor side. That means from the unaffected side, the patient's own skin will be removed and it will be used for the grafting. And it is the current standard of care in burn surgeries. And the advantages of using autograft means the chances of rejection will be very less, and there will be easy and fast healing also will happen. So these are the advantages of autografting, and it is the current standard of care in burn surgery. So we will see the other options also. What is allograft? Allo or the heterologous graft means skin obtained from the another person. Okay, allo or hetero means from the another person of the same species. Okay, and what is a xenograft or the heterograft? It is also known as a heterograft or the xenograft. It is a skin taken from other species such as pigs. Okay, so what is the difference between allograft and the xenograft is allograft means that skin is obtained from another person from the same species, but xeno means it is from the different species. Okay, and the final option, one more you have to understand, that is the synthetic skin substitutes. So these are the manufactured products that work as that usually work as the skin equivalents. Okay, if there is no choice for the allograft or the autograft, then the synthetic skin substitutes also can be used. That is a manufactured products which works as skin equivalents. Okay, so that's all about the 13th question, and that also is clear for you now. Now we will move on to the we will move on to our the last question in our series, the 15th question in our series, that is AFP is produced by. So the question is very simple. AFP is produced by. So the options for you are option number A, lungs, option number B, kidney, option number C, heart, and option number D, liver. So AFP is produced by dash. Easy question, last question. So the answer is liver. Okay, liver is producing the AFP. So you will see what is AFP and what is its clinical significances. Okay, so we know that the AFP stands for alpha fetoprotein. Okay, you know that, and it is a protein made in the liver of a developing baby. Okay, and a developing baby, and AFP levels are usually high when a baby is born, but it falls to very low levels by the age of 1. Okay, and healthy adults should have very low levels of AFP. So this is normal about the AFP. AFP means it is an alpha fetoprotein, and it is produced by the liver, and the production will be high in the developing baby, and it falls to very low levels at the age of 1, and the healthy adults individuals, its level is very low. Now we will see the clinical significance of AFP. We know that the high levels of AFP can be a sign of liver cancer or cancer of the ovaries or testicles, as well as non-cancerous liver diseases such as cirrhosis and hepatitis. Okay, so AFP indicates liver cancer or the other liver diseases if the value is high in an adult. Okay, so liver cancer or cancer of the ovaries or testicles, as well as non-cancerous liver diseases. So in the babies, in the children, if the AFP, why we are checking the AFP blood test? When the fetus in vitro, also we can check for the AFP levels, because AFP blood test is also used to check a developing fetus for risk for the birth defects and genetic disorders such as neural tube defects, Down syndrome, etc. Okay, so this is the significance of testing AFP in vitro and in adults. Okay, so with that we have come to the end of this section, and I thank everyone who watched the video till the end, because as I told in the beginning, each and every question and its explanation itself is very important. So thank you for watching the video till the end, and kindly stay tuned and stay in touch. So we will be coming with another set of questions in the JIPMER SCT series very shortly. Till that time, see you. Bye. Thank you.